When it comes to clinical practice, pulmonary embolism can be incredibly deceptive and therefore very hard to diagnose. But when it comes to the boards, you'll notice that they use a very classic pattern for your patients. You just have to know what to look out for. My name is Maruf, and in this video, we'll go over pulmonary embolism exactly the way the PANCE wants you to know it. Let's dive right into it. One of the most difficult things about pulmonary emboli is that a lot of the symptoms that are found in PE can be found in other diseases as well. That's why it's going to be very important to look at what's actually happening in a PE to try to find those unique patterns that make it stand out from those other diseases. Starting with the fact that when it comes down to a PE, all the symptoms will arise from an acute occlusion of one of the pulmonary arteries or one of its branches. Now, this blockage makes it very difficult for blood to get from the respective pulmonary tissues and pick up oxygen, and that will eventually lead to that classic manifestation of shortness of breath and a pleuritic chest pain. What you'll find is that depending upon how big that clot is or how proximal it is within those pulmonary arteries, the symptoms will generally become more and more prominent. For example, as the heart recognizes this decrease in blood oxygen, it'll start to beat a lot faster in hopes that that tachycardia can make up for that oxygen deficit. This is why sinus tachycardia is one of the most common findings in PE, although obviously not very specific. Now, some of these patients feel so short of breath that they start breathing very fast as well, making tachypnea another fairly common manifestation of PE, although again, not very specific. So this tachypnea or hyperventilation will eventually lead the patient to breathe out a lot of that CO2, which is the major acid in your bloodstream. So that can eventually lead to a respiratory alkalosis when left untreated, although again, that finding is not specific to a PE. Now, as you get more and more severe occlusions, the patient will eventually succumb to the inability of those pulmonary arteries to pick up oxygen, leading to actual hypoxia in these patients, and it can start to get pretty bad from there. You'll notice that as these clots get more and more massive, like a saddle embolism, then your patient will become very unstable. Remember that the right ventricle is in a circuit with the pulmonary vessels, and then the left ventricle. If there's a big clot in the way, then blood can't leave the right ventricle nor fill up the left ventricle, leading to a massive decrease in cardiac output out of that left ventricle. And that in turn can lead to significant hypotension and syncope. Now, on top of that, the right ventricle has a much harder time now pumping against this obstruction within the arteries, making the pressure build up within the right ventricle and eventually leading to leakage of things like proBNP and troponin from that resultant injury. Now, most patients don't magically develop clots within their pulmonary arteries. Instead, they usually have significant risk factors that'll allow for that thrombus to form. That's why one of the most important components to differentiating a PE from other diseases that can cause chest pain and shortness of breath is by identifying the patient's risk factor for developing a clot. Now, obviously, the most important risk factor for developing a PE will be having signs of a current DVT, since that clot in the extremity could easily pop off and fly into your pulmonary vessels. So if you see a patient coming in with chest pain or shortness of breath, even if it's mild, and they have signs of a current DVT, then that is a PE until proven otherwise. Now, the remainder of the risk factors aren't as strong, but their presence should at least make you consider PE as a possibility. For example, if your patient had a prior PE or a prior DVT, then it's certainly possible that that patient could have developed a clot again, and you should at least start thinking about the possibility of a PE. One of the most popular risk factors on the PANCE is a patient who's had a recent surgery. So while you're in surgery, not only are you going to be in a sedentary state of stasis for a prolonged period of time, but your body is also undergoing a significant trauma, and that can make you temporarily hypercoagulable. Another common risk factor for developing a clot is recent hospitalization. Remember, spending days in a hospital bed isn't just uncomfortable on the back, it also allows for stasis of your blood for a prolonged period of time, giving your blood an opportunity to clot and in turn even cause a PE. Going off of a similar notion, long drives or long flights where you're sedentary for like 6 hours can also significantly increase your risk of developing a clot. Moving along, we find that malignant tumors are notorious for making patients hypercoagulable. So, if you see that malignancy history in a patient with chest pain and shortness of breath, then you should immediately put PE on your differential diagnosis. Similarly, very high levels of estrogen in the body can also make a patient very hypercoagulable. This can range from being pregnant or recently pregnant to even just taking birth control pills or hormonal replacement therapy. Let's move on to the next risk factor, which is an underlying hypercoagulable disorder like factor V Leiden, protein CNS deficiency. Now, it's pretty rare in clinical practice to actually see these hypercoagulable disorders, but if these patients come in with chest pain or shortness of breath, then you should definitely consider PE as a possibility. Lastly, aging sucks balls, and that's going to include having an increased risk of developing clots. So, in general, if you have a patient who is older than the age of 50, then this alone should trigger PE as a concern in your mind. What makes PE so tricky in clinical practice is that it can present with an array of symptoms, anything from mild to just straight up death. But we'll break it down in a very simple way as you'll see it on the boards. Now, the most common presentation for PE is going to be some form of chest pain or shortness of breath. Now, that chest pain might be described as pleuritic, but not always. And that's because when that PE is small, usually the symptoms are very mild and vague as well. If the PE is larger, then the patient will give a more classic presentation, each of which should further and further increase your suspicion for a PE. For example, if your patient has an acute, all of the sudden development of shortness of breath or pleuritic chest pain, that's a pretty classic and concerning presentation for PE. So that all of the sudden nature should already make you worry about a PE as a possibility. They may even develop hypoxia and tachycardia if the disease is severe enough, again, further highlighting the possibility of a PE in this patient. Now, this might sound like a pneumonia as well, but the PANCE will usually steer you away from pneumonia by providing you a normal lung exam, like normal auscultation, or a normal chest x ray. It's important to note here that while patients with pneumonia will always have an abnormality on auscultation or on chest x ray, at least on the PANCE, patients with a pulmonary embolism will always have a normal auscultation and chest x ray, which again should further move you away from pneumonia and instead towards a PE. Now, I'm sure some of you are already going like, hold up, Maruf, what about those Westermarck signs or that Hampton hump sign where I see that dome-shaped opacity from pulmonary infarction? Don't I need to know those? This is that one time I'm going to tell you, don't worry about it. There's so much you need to know about PE that is so much more important than these arbitrary x-ray findings for PE, which are extremely low yield by comparison. So just know that there is this thing called the Westermarck sign and Hampton hump sign that you might see in a PE, but I wouldn't fret much beyond that. Lastly, in a massive occlusion of the pulmonary artery, you may see very, very severe disease. Remember that a critical blockage can lead to a significantly decreased cardiac output. This, in turn, can manifest as hypotension and syncope, two symptoms that should always put PE as part of your differential diagnosis. So I'm sure you guys have figured out by now that the symptoms of pulmonary emboli can be very diverse and overlap with these other diseases like pneumonia or maybe even ACS. And for that reason, I can appreciate it can be very difficult for students to know what the next step is. I think most of you know that a CT pulmonary angiogram is going to be the most important way to diagnose a patient with a PE, where you're going to give this bolus of contrast that shows up as bright white within those pulmonary vessels, highlighting areas of clots that remain a dark gray. However, you can't just order CTs on every single patient that has shortness of breath and chest pain. That's a lot of cost to the medical system and a lot of unnecessary radiation for patients. Now, in clinical practice, we navigate these issues by using these handy tools called Wells criteria and PERC score. We use the Wells criteria first to determine if the patient is high risk and should go straight to CT, or if they are low risk and go to PERC score instead. If the patient needs PERC and the PERC score is 0, then you can effectively rule out PE without any testing. However, if the PERC score is anything other than 0, then you should order a D-dimer on that patient. Now, D-dimers have a very high negative predictive value. In other words, if the D-dimer is negative, then you know you don't have a PE. Now, if the D-dimer is positive, then it's unclear what the cause of that elevation is, and it could be something from as simple as an infection all the way to something as severe as a PE. And in that case, you have to get the CT study next to rule out PE as a possibility. Now, this is a very highly complex algorithm, and most of us don't have this scoring system for Wells and PERC memorized. We're just going to look it up on MD Calc. But obviously, you can't use these fancy websites and calculators on the boards. So the PANCE does not require you to memorize and calculate Wells and PERC scores. That would be asking way too much of you. Instead, they simplify the process into 3 categories: patients who probably have a PE, patients who maybe have a PE, and patients who just don't have a PE. Now, this way, students feel less ambiguity about what the next best step is going to be and won't go hunting those test makers down to complain about how their questions are unfair. Now, patients in the probably group have very classic or even severe features of PE. For example, if your patient has that classic pleuritic chest pain and shortness of breath, plus any of those risk factors we talked about, then they probably have a PE, and these guys need to go to CT next for confirmation. Now, the PANCE also likes to treat unexplained or unclear symptoms of chest pain and shortness of breath as a PE trigger word. So, for example, if your patient has sudden development of pleuritic chest pain or shortness of breath, but without a clear cause, then for the sake of the PANCE, this is a PE until proven otherwise, and you should get a CT on this patient to confirm that diagnosis. Now, in these patients, they may not even give you the risk factors for PE, but they may help you rule out other possibilities in the clinical vignette. For example, they might help you rule out pneumonia by giving you a normal lung exam or normal x-ray, or help you rule out pericarditis by giving you a normal EKG without any ST elevations. The PANCE expects that as the question stem crosses off all these other possibilities, your suspicion for PE should become more and more. Sometimes you'll have a clinical vignette where a patient is decently hypoxic, like 92% or lower, but there's no clear explanation for that patient's hypoxia. Again, they might give you a normal chest x-ray to prove to you, hey, there's no pneumothorax, no pneumonia, no heart failure to explain the patient's symptoms. Well, for the sake of the boards, any patient with unexplained hypoxia has a PE until proven otherwise. And again, that patient needs a CT next for confirmation of that disease. A popular way that the PANCE tests PE is by presenting a patient who presents with significant hypotension or a syncopal event without a clear explanation. Again, they might have a normal x-ray that rules out concerns for things like pneumonia with septic shock or pneumothorax or cardiogenic shock, and they may also mention normal or moist mucous membranes to steer you away from like dehydration concerns like from severe diarrhea. These patients who present with unexplained hypotension are very concerning for PE and will eventually get a CT to confirm their diagnosis. However, this is the only type of patient that will actually get treatment first because of how unstable they are. So yes, they are going to get a CT, but they need treatment first, and we're going to talk about that later. Now, while most of these patients have had moderate to severe symptoms that make them high risk for PE, having signs of a current DVT, like with swelling in your leg or pain, is going to be the one exception to that severity rule. If you have a patient that comes in with signs of a DVT, then it doesn't matter if their chest pain or shortness of breath is super mild even. That is a PE until proven otherwise. So if your patient doesn't have any of those previous features, then they either fall into a maybe PE category or an unlikely PE category. Now, to be in the maybe category, your patient still needs to have unexplained symptoms of chest pain and shortness of breath, but those symptoms have to be mild. On top of that, they're only allowed to have one risk feature. Now, that could be in the form of one of the risk factors that we previously discussed, or it could be a minor vital sign abnormality like a mild tachycardia, less than 110 beats per minute, or a mild hypoxia like 93, 94%. But the key is that the patient still has to look well with mild symptoms. The goal for this maybe group is to determine, do they actually need a CT scan? This is where that D-dimer comes into play as the next step for these maybe patients. If the D-dimer is negative, then you've ruled out PE and you no longer need to do any further testing. On the other hand, if the D-dimer is positive, then it's unclear what could have caused that positive value, whether a real deal PE or some other confounding factor. And in that case, these patients need to get a CT to clear up that ambiguity. So a good thing to note here is that when patients have just one of these features, then they can stay in that maybe group and get a D-dimer next. However, if the patient has two or more of these features, then they're going to graduate to that probably group because the PANCE is trying to stack these risk factors to make PE more obvious, and these patients can't just get a D-dimer, they need to get a CT next. The final group is the unlikely group, whom don't need any PE testing, whether with D-dimer or CT, because they don't have any of the features from the previous two groups. Now, these patients have to still have mild symptoms of their chest pain and shortness of breath, but they can't have any risk factors for PE, and they can't have any vital sign abnormalities, not even the slightest tachycardia or hypoxia. It may not be clear what these patients have, but it is clear that they don't have a PE because their symptoms are mild and they lack every risk feature that we've discussed. Thus, no further testing is needed from a PE standpoint. So let's put this all together so that we have a nice, clear algorithm that you can follow the next time you see a PE type question. So firstly, if your patient has classic chest pain or shortness of breath symptoms and have at least one risk factor, or they have unexplained symptoms of sudden chest pain, or they have unexplained hypoxia or tachycardia with their chest pain and shortness of breath, or maybe they just have mild symptoms, but they have signs of a current DVT, then this is a PE until proven otherwise in every single one of these scenarios, and these patients should go for immediate CT pulmonary angiogram as that next step. Now, if you have a patient that's pregnant, then they should instead go for a VQ scan. In a VQ scan, you give the patient a radioactive gas to inhale into their lungs and a radioactive intravenous solution to light up their pulmonary vessels. And then you can look for a mismatch of ventilation and perfusion and see if there is a possibility of a PE. So it's not as good as a CT, but it does avoid a lot of that radiation that comes with it. Also, I want you to note that patients with unexplained chest pain and shortness of breath who have hypotension is also very highly concerning for PE. However, these patients are deemed unstable, and you should never send an unstable patient to CAT scan. There's no one there to monitor the patient if things happen to get worse. Instead, you should treat first with thrombolytics like TNK, and then send the patient to CT after you're done treating them. The theory here is that the patient might die in any minute, so let's blindly treat so that we can prevent any worsening, and then we'll confirm the disease with CT after we've treated them. Now, this is not how we typically practice in real life, but for the boards, this is very set in stone. Unstable PE equals treat first, diagnose later. If you have a patient with unexplained mild chest pain or shortness of breath symptoms, then they already find themselves in either the maybe or the unlikely group for PE. Here, if the patient has one risk feature, like a risk factor or mild vital sign abnormality, then they are deemed as maybe PE, and you should get a D-dimer as your next step. If that D-dimer is negative, no PE. However, if the D-dimer is positive, then it's not clear what they have, and it's important to get a CT next to determine if they truly do have a PE. Now, only if the patient lacks all of the features from the previous groups can you say that PE is unlikely, and in this case, you don't need to do any further testing. If you do end up getting a CT on your patient and it shows a pulmonary embolism, then the next step is to start these patients on heparin and admit them. Now, eventually, they do go home on a DOAC or direct oral anticoagulant like Eliquis or Xarelto. But if you have a pregnant patient, then Lovenox is a much safer option as opposed to these DOACs. You'll usually keep patients on anticoagulation for about 3 months, particularly if their risk factor was temporary, like OCP use or surgery, pregnancy. However, if you don't foresee the patient's risk factors changing anytime soon, like in cancer or underlying hypercoagulable diseases, then you may want to keep these patients on anticoagulation for much longer periods of time or maybe just indefinitely. I wanted to finish off by mentioning a very rare but very testable concept in PEs, and that is that EKG finding of an S1Q3T3. Now, if you see this iconic pattern on EKG where you get this deep S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3, then for the sake of the PANCE, this is a PE until proven otherwise. Let's finish off by practicing that algorithm that we learned with the following scenarios. Now, take a look at each of these questions and make sure you understand what the next step is, and more importantly, why. Now, the answers are on the top left, but try to ignore looking at them until you're ready. Otherwise, make sure to check out the next video where I'll discuss aortic dissection, a personal favorite of mine. I'll see you there.